Hello and welcome to my YouTube channel, AnatomyMentor. Today, I'll be discussing the very important topic of histology, which is the histology of the respiratory system. And in part one, which I am discussing in today's video presentation, covers the histology of the trachea and the bronchial tree. So today's learning objectives are that we are going to enumerate the cells comprising the respiratory epithelium, and we shall discuss the histological modifications or changes that take place in the wall of the respiratory tract from the trachea to the alveoli. Also, we'll be appraising the histological basis of immotile cilia syndrome and asthma. So let's start by dividing the respiratory system, or we can also call it the respiratory tract, into two main parts on the basis of the gross anatomy. On the basis of gross anatomy, the nasal cavities and the nasopharynx is known as the upper respiratory tract, whereas the part of the respiratory tract, which is the larynx, trachea, and below the trachea, the bronchi, bronchioles, alveoli, all which are present within the lungs, this whole segment can be called the lower respiratory tract. So the cutoff point is simply the part above the larynx is upper respiratory tract, whereas the part below the larynx is the lower respiratory tract. But if we were to divide the respiratory tract on the basis of the detailed histology and function into segments, then we would divide it into two large parts, one known as the conducting portion, which is the initial part, and then would be the respiratory portion. Now, what do we mean by the conducting portion? This consists of those air passages that lead to the sites of respiration in the lungs, where eventually gaseous exchange occurs. Now, these air passages that are leading to the sites of respiration are nasal cavities, nasopharynx, larynx, trachea, bronchi, and the non-respiratory bronchioles. And within this system, the internal bronchi and bronchioles, when we say internal bronchi, we mean the bronchi within the lungs, they constitute the bronchial tree. Then what is the respiratory portion? This is the part of the respiratory tract in which the actual gaseous exchange is going to occur, namely the respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli. First, let's define the respiratory epithelium. Now, this is the epithelium which is lining most of the nasal cavities and the conducting portion of the respiratory system. This consists of the ciliated pseudostratified columnar epithelium, which is resting on a thick basement membrane. Now, the word pseudostratified implies that this epithelium appears to be multi-layered, but in reality, there is a single layer of cells which are resting on the basement membrane. Now, there are 5 cell types within the respiratory epithelium. The most common are the columnar cells, which have cilia on their luminal surface. And then the goblet cells, which are the cells that contain the mucinogen granules and are responsible for mucus production. Mucus is the liquid or the thick viscous fluid which is being produced, and this is the one which is responsible for getting rid of the particles and the other foreign agents from the respiratory tract. The brush cells are also present within the respiratory epithelium, which are chemosensory cells, and small granule cells, which are the component of diffuse neuroendocrine system, whereas some basal mitotic stem cells are also present within the epithelium, which divide and replace all the other cell types. Okay, so here is the histomicrograph, which is showing us the stain section of the respiratory epithelium, and a special stain has been used over here, which has stained the basement membrane a blue color, and you can see the basement membrane is thick and prominent. Now, on this membrane is the respiratory epithelium, the cells of which have a reddish color over here, and at the luminal surface, you can see the arrow is pointing towards the cilia on these cells. Now, as I told you before, this is a pseudostratified epithelium, so although it appears to have multiple layers because of these nuclei being at different levels, there is actually only a single layer of cells which is present on this basement membrane. The reason of the false appearance of multiple layers is because not all of the cells reach the luminal surface and they just end midway within this epithelium. So their nuclei, in comparison to the nuclei of the other cells which would be reaching the luminal surface, they are at different levels, giving the false impression when you look at this epithelium initially through the microscope, you might suppose that there are multiple layers, but actually there is a single layer of cells. So here we can see these are the tall columnar ciliated cells. And here G, the labeled structure, is the goblet cell. The goblet cell is a round cell. As you know, a goblet is a thick, round drinking cup. So that's why it's called the goblet cell. It typically contains mucinogen granules, which when released onto the luminal surface become hydrated and transformed into the mucus. So let's look at now a clinical condition which is known as squamous metaplasia. So I'm going to discuss this side by side along with the basic histology. Now, in smokers or people who are exposed to polluted environments, the continuous interaction with the smoke particles, the entrance of the smoke particles within the respiratory tract can cause the epithelium of the respiratory tract, which is the pseudostratified ciliated epithelium, to undergo some changes. It can transform into the stratified squamous, the multiple layered epithelium. So here is the histomicrograph, which is showing the actual change of the pseudostratified columnar epithelium into the stratified squamous epithelium. This transformation of the epithelium is actually an adaptive process which allows or enables the epithelium to deal with the continuous exposure to the noxious chemicals in the smoke. But on the downside, such long-standing squamous metaplasia can also cause cell dysplasia, which means changes in the cells which can eventually become precancerous. So it can lead to cancer. Another clinical aspect that I would like to discuss along with the basic histology is that, as you've seen, the cilia, they are present on the luminal surface. They are the luminal modifications of the tall columnar cells in the respiratory epithelium. These cilia are not static, which means that they are actually moving. They have a specific direction of movement, that is the beating movements of the cilia, which are going to remove the harmful compounds and the debris from the respiratory tract by beating in a particular direction, and that direction is upwards, or you could say towards the outside along the bronchial tree and trachea. So the harmful compounds, along with the mucus within, which actually entraps these particles, the smoke particles or the other pollutants, they are removed by the unidirectional beating of cilia from the respiratory tract. This is known as the mucociliary escalator. You know, an escalator means a moving staircase. So the beating movements of the cilia have been compared to an escalator. But this condition, which normally takes place, can be, you could say, unempowered, or it could be having some defect in case of the condition, which is the immotile cilia syndrome, also known as primary ciliary dyskinesia. So in this condition, there is a structural abnormality in the dynein arms of the cilia. So the cilia are the luminal modifications, cell surface modifications of ciliated columnar cells, and they consist of the microtubules, which are arranged in an axoneme pattern, in which there are two central microtubules surrounded by the doublets of microtubules, that is known as the 9+2 pattern. So the dynein arms of the cilia, if they are having some structural abnormality, this will cause the cilia to become immotile. And when they will lose their motility, then obviously this mucociliary escalator or apparatus becomes dysfunctional, it becomes non-functional. And so the clearance of the mucus secretions along with the debris and the harmful compounds is impaired. And this in turn can cause repeated respiratory infections, and it can also cause infertility. Now, why would it cause infertility? Well, you see, in case of females, the infertility would be due to the involvement of the cilia of the cells which are lining the fallopian tube. And the beating of the cilia of the cells lining fallopian tube have an essential role in the transport of ovum across the fallopian or uterine tube. Since that is affected in case of females, it can cause a female infertility or subfertility. Whereas in males, the similar cilia, which are responsible for the movement of the spermatozoa, are present within the efferent ductules of the male genital tract. And over there, their impairment can affect the transport of the sperm. Additionally, the flagellum of the sperm also has an intrastructure, an ultrastructure, which is similar to the microtubule unit of axoneme, and that becomes affected, causing the male subfertility or infertility. The Carter-Jenner syndrome is a condition in which there is sinusitis plus bronchiectasis and situs inversus. So here the bronchiectasis, in case of bronchiectasis, the lumen is enlarged. When you talk about the bronchioles, there's an enlarged lumen and there is mucus collection within the lumen and the cilia function has been impaired. Impaired ciliar function also causes repeated infections of the sinuses. And situs inversus is the transposition of the thoracoabdominal viscera from their normal location. That is known as the Carter-Jenner syndrome. Okay, now that we're going to start the discussion of the basic histology of respiratory tract, we're going to begin with the trachea, commonly known as the windpipe. So we know that the trachea, our trachea is over here. It's lying within the neck in the midline. It's a short, flexible air tube about 1 inch in diameter and about 10 centimeters long. It begins at the level of the 6th cervical vertebra, and it ends at the level of the intervertebral disc between 4th and 5th thoracic vertebrae. This is known as the level of the sternal angle, where the trachea ends by dividing into the 2 main or principal bronchi. The wall of the trachea has the following layers from the inner to outer aspect. Innermost is the mucosa, which contains the respiratory epithelium. We just talked about it. We saw the features of respiratory epithelium. So that is present as the innermost layer of the trachea. And this is resting on elastic fibers, which are present in the lamina propria, which also contains seromucous glands. Then if we look outer to the mucosa, there is the submucosa, which is dense connective tissue, also containing seromucous glands, as well as C-shaped rings of hyaline cartilage, bridged by smooth muscle posteriorly, which is known as trachealis. And the outermost layer of the wall of the trachea is the adventitia, which is the loose connective tissue present most externally. Within the tracheal wall, there is lymphatic tissue present in both diffuse and nodular form in the layers which are lamina propria and submucosa. This is actually the component of BALT, that is the bronchus-associated lymphatic tissue. So this has an essential role in immunity and the defense system against the microorganisms and other harmful foreign particles. Here is the histomicrograph of the trachea. So the section has been taken through the wall of the trachea, and you can see the layers. That the innermost layer is the respiratory epithelium, which is, as I told you, the typical pseudostratified ciliated columnar epithelium. Beneath it is the lamina propria, rich in elastic fibers, and over here is the submucosa with the seromucous glands responsible for production of the secretions as well. And over here you can see this here is now the cartilage. P is for the perichondrium, or the layer which is surrounding the cartilage. And here you can see the cells of the cartilage, which is hyaline cartilage. So the trachea, remember, contains C-shaped rings of hyaline cartilage. This here is a histomicrograph, which is a section through the whole of the trachea. And I've included this over here in my video presentation. So we can see, if you just follow the laser pointer, that this is the C-shaped ring of hyaline cartilage. And on the posterior aspect, remember, this cartilage is not present. It is replaced by the bands of smooth muscle known as trachealis. So T over here is for trachealis. And you can see also over here a few strands of the longitudinal muscle. So remember that this is the flexible tube. The trachea consists of fibroelastic tissue and cartilage, and this permits the expansion in diameter and extension in length of the trachea during inspiration, and passive recoil which takes place during expiration. Now, Trachealis muscle, remember, is the muscle which relaxes during swallowing when there is passage of food through the esophagus, as the esophagus is going to bulge into the lumen of the trachea. So behind the trachea is the food pipe, also known as the esophagus. When a bolus of food passes through this esophagus, it produces a bulge in the esophagus, and to accommodate for that bulge in the esophagus, you can see the trachealis muscle, which is present posteriorly within the tracheal wall, it relaxes. But the elastic fibers present within trachea, they prevent excessive distension of its lumen. The trachealis muscle, it contracts during coughing. We know that coughing is the reflex, the adaptive, or you could say the protective reflex of the human body, which occurs whenever some harmful substance or some irritant, it has entered our respiratory system. So this coughing, essentially what it does is that it narrows the tracheal lumen. And as the tracheal lumen becomes narrowed because of the contraction of the trachealis muscle during coughing, this increases the velocity of the expulsion of air, as well as the forceful ejection of the material or the irritant which initially caused the cough reflex from the air passage. So this is a similar example, like if you were, let's suppose, watering your garden plants, and you've got a hose, a pipe in your hand, and if you press on that pipe, you are going to be decreasing its lumen, but the velocity, or you could say the force, the distance which is covered by the water which now leaves the pipe, is going to be greater as it was before. So this is a similar mechanism when we're talking about basic physics, that as the lumen of the trachea decreases, this actually increases the velocity of the expulsion of air from the trachea. Now let's come to the bronchial tree. We can see over here that in green is the larynx, and then in purple is showing us the trachea, the windpipe, with these C-shaped rings of hyaline cartilage. And over here in yellow is the region where we can see this trachea has divided into two main bronchi, which are known as the main bronchi or the principal or primary bronchi. These are the right bronchus and the left bronchus. Now keep this in mind that the right bronchus, it is shorter in length, and it is also wider, and it is more vertical, so more in line with the trachea. Whereas the left bronchus is longer, but it is having a narrow diameter in comparison to the right, and it is more in angle with the trachea. So if there is entrance of any foreign body in the trachea, it tends to go into the right principal bronchus because its lumen is wider and more in line with the trachea. Also, I would like to tell you, at the division point of the trachea into the two principal bronchi, there is a narrow ridge of cartilage, C-shaped ridge of cartilage, which is known as the carina. So these are the main bronchi, and these primary or main bronchi will then further divide into the secondary or lobar bronchi, which are for the specific lobes of each lung. The right bronchus is going to enter the right lung, and it will divide further into these areas which are colored in pink. These are representing the secondary or lobar bronchi. You can see 1, 2, 3. These are 3 on the right for the 3 lobes of the right lung. And these are 1, 2, 2 on the left for the 2 lobes of the left lung. Then furthermore, you can see the tertiary bronchi, which are in blue. These tertiary bronchi are also known as the segmental bronchi, and these are for the bronchopulmonary segments, which are 8 in the left lung and 10 in the right lung. Although considering the division of the further segments, we can also consider the left lung to have 10 segments, just as we are talking about the right lung having 10 segments. Okay, so over here, then again, this shows us the color-coded different parts of the bronchial tree. And we can see how these are the main bronchi, which are right and left, and then the lobar bronchi, 3 on the right side for the 1, 2, 3 lobes of the right lung, and 2 on the left for 1, 2, the 2 superior inferior lobes of the left lung. And you can see the further smaller bronchi branching out from these bronchi. So what is a bronchopulmonary segment? I would like to define a bronchopulmonary segment. You see the tertiary bronchus, which is the segmental bronchus, plus the lung parenchyma that it is supplying, they collectively form the bronchopulmonary segment. The significance is during surgical resection because each segment with its own blood supply and connective tissue capsule can be easily removed in certain diseases. So here is a very simple diagram which is showing us a bronchopulmonary segment. Now this here is a bronchopulmonary segment because you can see this is the part where the segmental bronchus is present, and the segmental bronchus, as it enters a specific part of the lung, this segmental bronchus then further divides into the bronchioles, which are terminal and respiratory bronchioles, and then further the alveolar sacs and the alveoli. So the part of the lung tissue plus this segmental bronchus, this is as collectively considered as the bronchopulmonary segment. And remember, the branching of the bronchus and bronchioles is accompanied with the branching of the pulmonary artery. Whereas the pulmonary veins, they are present between adjacent bronchopulmonary segments. So this is the, you can see the connective tissue present between adjacent bronchopulmonary segments, and here lie the pulmonary veins and their branches. Also, I would like you to note over here that when we talk about a lung lobule, what do we mean by a lung lobule? The lung lobule is simply that portion which is representing, you can see over here, the bronchiole, and then its further branching portions. That is the lung lobule. Bronchi, let's come to their histology. We talked about the histology of the trachea and then its further division into primary, secondary, and tertiary bronchi. So now we should look at the histology, the detailed histology of the bronchi. The bronchi do have cartilage. The larger bronchi have the C-shaped rings of cartilage, which are similar as in the trachea. But as we go further down the bronchial tree, these rings become replaced by plates of cartilage, and there is also a circular layer of smooth muscle, which gives a folded appearance of bronchial mucosa in cross sections. In the larger primary bronchi, these rings will completely encircle the lumen, but then furthermore, the cartilage plates which are present in the smaller bronchi are visible as isolated regions of cartilage. So what are the layers in the wall of a bronchus? Well, innermost is the mucosa, which also contains the respiratory epithelium resting on basement membrane. But the difference now is that the height of this respiratory epithelium has decreased and the lamina propria is thin. Also, there is a muscularis, which represents crisscrossing bundles of spirally arranged smooth muscle. Then comes submucosa, which has loose connective tissue and glands, and adipose tissue is now present in the larger bronchi, and the mucosa-associated lymphoid tissue, which is MALT, becomes more abundant in smaller bronchi. There are discontinuous cartilage plates, which become smaller as the bronchial diameter decreases. Outermost layer is adventitia, which is dense connective tissue, continuous with adjacent structures like the lung parenchyma. Now here we're going to look at the histomicrograph of, we can see this is a cross section through the bronchus, and this is a tertiary or segmental bronchus. And if we look over here, this is a hematoxylin eosine stain section, and we are looking at these are the layers of this bronchus. Well, innermost you can see is the epithelial layer, and as I told you, this has a folded appearance, and beneath this is the lamina propria. And then beneath the lamina propria, we can now see this is here the smooth muscle, and also we can see some glands, and C is labeling this isolated plate of hyaline cartilage. Now, the bronchial tree, as I told you, the tertiary bronchi, when they divide further, they form smaller and smaller bronchi, and their terminal branches are eventually called bronchioles. But when do we label them as bronchioles? Well, when the diameter of these air conducting passages becomes 1 millimeter or less, this is the point when now we label them as bronchioles. And the bronchopulmonary segments, they are further subdivided into pulmonary lobules. As I showed you in the previous diagram, each lobule is the part which is supplied by a bronchiole. And the lobules are pyramid shaped with their apex directed towards the hilum of the lungs and the delicate connective tissue septi, which are partially present to separate the pulmonary lobules. The diameter of 1 millimeter or less, when we talk about the histology of bronchioles now in detail, first thing to be considered is, of course, that their diameter is 1 millimeter or less. The other important point, the basic histology when we consider of the bronchioles, keep in mind that they do not have cartilage and they do not have submucosal glands. So this is the important significant change that has taken place within the bronchioles, that they do not have cartilage and they do not have submucosal glands. And both these components were present in the bronchi and in the trachea. The larger bronchioles, their epithelium also has now changed from respiratory pseudostratified epithelium to a simple ciliated columnar lining with a fewer number of goblet cells. Relatively thick layer of smooth muscle is present. So here is the histomicrograph and H&E stain section of the bronchiole. And in the cross section, we can see, so the innermost is the epithelium of the mucosa, which is now the simple columnar epithelium. And now you can see that this is surrounded by a very thick and prominent layer of smooth muscle, which has been pointed out by the black arrows over here. So this prominent layer of smooth muscle is an essential identification point of the bronchiole whenever you're looking at a section of the lungs. But you can see over here that there is no cartilage and there are no glands. What about the terminal bronchioles, which are the last parts of the conducting system of respiratory tract? Well, they are lined with simple cuboidal epithelium. So the height of the epithelium has further decreased from simple columnar to simple cuboidal. And the goblet cells have now become replaced by another cell type, a new cell type, which are the Clara cells. Now, what are the Clara cells? The Clara cells increase in number now. Ciliated cells have decreased in number along the length of bronchiole, but the smooth muscle circumferential layer is prominent. Let's look over here at the section of the terminal bronchiole now, which is the last part of the conducting system. We can see the epithelium over here is simple cuboidal epithelium now, and it is surrounded by this prominent circumferential layer of smooth muscle. And these are the only layers which are prominent and help us in identifying this part of the respiratory tract. And now, if we were talking about Clara cells, which are the new cell population which have appeared, well, these are also called the exocrine bronchiolar cells. And these are non-ciliated dome-shaped cells. Their apical cytoplasm contains many secretory granules, and they perform different functions, in which the important functions are, the first one is secreting a substance known as surfactant, which prevents collapse of the bronchioles. Also, it has a role in detoxification of inhaled harmful compounds by the smooth endoplasmic reticulum P450 enzyme system. And another function is secretion of antimicrobial peptides such as lysozyme and immunoglobulin A and cytokines for local immune defense. Also, the subpopulation of stem cells is present in the form of Clara cells, which replace other cells of bronchiolar epithelium. So if we were to look just at the Clara cells and at a higher magnification within the terminal bronchioles, we can see these are the Clara cells. So these are dome-shaped cells, and they contain the secretory granules in their apical cytoplasm. And this is the special stain. Okay. Remember, when we talk about the respiratory system, keep in mind it is the autonomic nervous system which is supplying this respiratory tract, and it controls the muscular contraction in both bronchi and bronchioles. Sympathetic innervation, remember, relaxes smooth muscle, whereas parasympathetic innervation constricts the smooth muscle in the bronchial tree, especially in the bronchioles. Why are the bronchioles affected, especially by the nerves? Because the thickness of the smooth muscle layer, as we saw in the previous sections, the relative thickness is much more in the bronchiolar walls when compared to other parts of the respiratory tract. Stimulation of cholinergic nerves also results in mucus secretion and bronchiolar vasodilation. So now we're going to talk about asthma. You know about this, you must have heard about this, and maybe you have some family members or friends who are suffering from asthma. We can define it as a chronic inflammatory disease involving airways of the lungs caused by a combination of genetic and environmental factors. It is characterized by obstruction of airflow due to sudden constrictions of smooth muscle in bronchioles called bronchospasms and inflammation of the bronchioles. So the typical symptoms in asthma are that there is the wheeze, the characteristic sound which is produced, cough, shortness of breath, also known medical terms as dyspnea, and a feeling of tightness in the chest region. The asthmatic medication which is typically prescribed is salbutamol, that is albuterol, which comes by the brand name of Ventolin, and other short-acting beta-adrenergic agonists are given because they are sympathomimetic bronchodilators. As we discussed in the previous slide, the sympathetic nervous system, it relaxes the smooth muscle within the bronchioles mainly. So this is the one which is going to be effective, the sympathomimetic, which means drugs which are going to mimic the effects of sympathetic nervous system are prescribed, as they will lead to the increase in the the air passageways diameter, that is the bronchodilators. The luminal diameter will be increased. Long-acting beta agonists such as salmeterol can also be given for severe asthma, and it is also given with a combination of the leukotriene antagonists such as montelukast. So leukotriene antagonists are given to counter the inflammatory process, which are going to prevent the release of the leukotrienes from the mediators of inflammation from the leukocytes. How do we define a respiratory bronchiolar unit? What is a respiratory bronchiolar unit? This is the smallest functional unit of pulmonary structure. It consists of a single respiratory bronchiole and the alveoli that it supplies. If we recall from the previous discussion, the respiratory bronchiole is the first part of the respiratory portion of the respiratory tract. So as we talk about the single respiratory bronchiole and the further parts into which it branches, they will all be involved in gaseous exchange, and that portion is known as a respiratory bronchiolar unit. Okay, so over here is now a histomicrograph of the lung tissue. And over here in the lung tissue, we can see that what we are looking at over here is the terminal bronchiole. These are the portions of the bronchial tree which are visible within the lung tissue. Here is the terminal bronchiole, and this is the last portion of the conducting part of the respiratory tract. It leads into this here these two respiratory bronchioles. Respiratory bronchioles have alveoli which are opening within the walls of the respiratory bronchioles. So this is the first part where gaseous exchange is taking place. This is now the respiratory portion of the respiratory tract, and these respiratory bronchioles then further lead into this portion which is AD, meaning the alveolar ducts. These are elongated airways that have almost no walls and only alveoli are surrounding them. And then come the alveolar sacs, which are the spaces at the termination of the alveolar ducts, and they are then further surrounded by these alveoli. So over here we can see these numerous alveoli. They give a spongy appearance to the lungs because of the round sac-like appearance, and air is present within these alveoli. And the respiratory bronchiolar unit that we just talked about is the part which is further ahead from this single respiratory bronchiole, and all the further structures, the parts which it gives rise to, the alveolar duct, the alveolar sac and alveoli, they would constitute a single respiratory bronchiolar unit. This is a table which is from the Genquera's Basic Histology, and it gives a very good summary of the different parts of the airways and their basic histology, mentioning the epithelium, the muscles and the skeletal support, whether there's cartilage or not, and the other specific functional features. So this is a summary of what we were talking about before. We can see the epithelium in bronchi is respiratory epithelium, similar to the one in the trachea, only the height of the epithelium is decreasing. So you can see as we go further downwards in the respiratory tract, this respiratory epithelium changes from the columnar to the cuboidal one, and you can see the goblet cells eventually become replaced by Clara cells within terminal bronchioles. And also we can see over here that if we look at the other layers, if we look at the smooth muscle, it is present within bronchi, but the prominent circular layer is present within bronchioles, which then becomes incomplete as we move further downwards. And eventually the alveoli, remember, do not have smooth muscle. They only have network of elastic and reticular fibers. And the epithelium within alveoli is consisting of type 1 and type 2 epithelial cells. We will be discussing them in detail in the second part of this discussion in the next video presentation. Over here, let's look at the cartilage. In bronchi, there are irregular hyaline cartilage plates, but in the bronchioles, the cartilage is not present. Also, the glands are also not present over here. And the functions I've already discussed with you. So before ending with today's topic, just a few questions which will help you in assessing your knowledge after having listened to this discussion on the respiratory tract histology. Well, the first MCQ is that I'm going to ask you about which of the following components, this list of components that you see in front of you, increases as proportion of the respiratory tract wall from the trachea to the alveoli. So which of these components is going to increase in quantity or number as we move distally within the respiratory system from the trachea to the alveoli? Well, the answer over here is the elastic fibers, because we can see that the elastic fibers is the one which are present within the alveoli. The cilia have disappeared, the cartilage have disappeared, the goblet cells have disappeared, and the smooth muscle has also disappeared. So elastic fibers is the correct answer for this MCQ. The second one is that which structural feature distinguishes between terminal and respiratory bronchioles? Terminal and respiratory bronchioles. Which structure is going to differentiate between them? You know, the terminal bronchioles are the last part of conducting portion of respiratory tract, whereas respiratory bronchioles are the first part of respiratory portion of respiratory tract. So the distinguishing point is the alveoli, because alveoli are present within the walls of the respiratory bronchioles. This makes gaseous exchange possible within these bronchioles, and this is why they're included within the respiratory portion of respiratory tract. So the distinguishing feature is the presence of the alveoli. Now, the third question is that which of the following features distinguishes a bronchus within the lung from the primary bronchi? Now, we know that the primary or the main bronchi are the first main division segments of trachea, and they are initially present outside the lung, but then as they branch further, we can see the rest of the components, they are present within the lungs. So which of the following features distinguishes the bronchus which is within the lung from the primary bronchi? Well, this is the irregular plates of cartilage, because the main bronchi are a direct continuation of, they're the initial branching segments from the trachea. So their cartilage is similar to that present in the trachea. They're the C-shaped rings of hyaline cartilage. But as we enter the lungs, then the cartilage within the bronchi is not in the form of C-shaped rings. Instead, it is in the form of isolated plates or irregular plates. And so C is the correct answer for this question. These are the reference books from which this topic was prepared. And this concludes with today's discussion on the histology of the respiratory tract. And if you liked today's discussion and you found it helpful, then please like and subscribe to my YouTube channel, AnatomyMentor. You can easily do that by just pressing on my picture, which is going to appear at the end of this video. Also, don't forget to press the bell notification. Just highlight or press the bell notification, turn it on. So when I'm going to come again with the second part of this topic, in which I'm going to be discussing the histology of the alveoli and the respiratory membrane in detail, you won't miss that topic. So thank you for your time. Take care and goodbye, and enjoy studying. Allah Hafiz.